Welcome to today's event on the role of biomarker testing in personalized healthcare and addressing disparities in cancer care and survival. I'm Washington State Representative Cindy Ryu, Chair of Women in Government. I'm excited to be joined by so many lawmakers and some great speakers to talk about today's important issue. I would like to thank Amgen for sponsoring today's event and their partners at the American Cancer Society Cancer Action Network, or ACS CAN, for organizing this briefing. Progress in improving cancer outcomes increasingly involves the use of precision medicine, which uses information about a person's own genes or proteins to prevent, diagnose, or treat diseases like cancer. Biomarker testing is an important step to accessing precision medicine treatments, including targeted therapies that can lead to improved survivorship and better quality of life for people with cancer. Biomarker testing is so important for connecting patients with the most effective treatments and clinical trials, not only for cancer care, but soon for many other conditions as well. Targeted treatments have come a long way in recent years, but not everyone is benefiting from the latest advances. There is currently limited and disparate access to biomarker testing. Improving access to biomarker testing and thereby access to targeted therapies, which is a strategy to reduce health disparities and improving outcomes for people with cancer. To kick things off, we'd like to show a short animated video from ACS CAN to explain a bit about today's topic, biomarker testing.
Imagine, scientists have developed a new way to use information from your own genes or proteins to help doctors diagnose or treat disease and improve survival and quality of life in conditions like cancer. Well, biomarker testing is here, and it's full of promise. Now imagine this: thousands of Americans who could benefit from this scientific advancement missing out because of lack of insurance coverage and other barriers. Americans who have been marginalized, including in communities of color and those who are insured through Medicaid, and people in rural communities far from academic medical centers, are less likely to benefit from these life-saving advances. A biomarker is a unique signal that is specific to a patient's disease and can be measured in blood or tissue. In cancer, biomarkers can include molecules like proteins and gene mutations found in cancerous cells. Cancer biomarkers are often notated by an abbreviation which can include numbers and letters. A positive test means the patient's cancer cells have that biomarker, and this information can be used to select the most appropriate treatment. Scientists are working to advance new treatments for cancer and other diseases by determining what biomarkers can convey about the effectiveness of different therapies. Currently, there are rapidly increasing numbers of biomarker-informed therapies doctors are using, and these therapies are leading to improved survival rates and better quality of life for people with cancer. And those better health outcomes could lead to lower healthcare costs. But private and public insurance plans are failing to keep pace with this progress. As biomarker-informed care continues to advance, ensuring equitable access to biomarker testing by improving coverage will be key to preventing new health disparities and dismantling barriers that prevent too many patients from benefiting from these innovations. So even if you're not a doctor or a scientist, you can help bring the promise of biomarker testing to all Americans who need it by supporting a law to extend coverage for biomarker testing and by educating friends, family, and policymakers about the importance of biomarker testing. Join ACS CAN in supporting policies that will ensure coverage of testing for patients, including those insured through Medicaid. Improving access to biomarker testing can lead to better patient outcomes and advance health equity for all.
Next, we're excited to hear from a provider on the front lines of cancer care and cutting-edge research. Dr. Debra Pat, an oncologist, breast cancer specialist, and executive vice president at Texas Oncology in Austin. Dr. Pat is in clinic today, so we recorded her remarks in advance of today's event.
Hi, my name is Dr. Debra Pat, and I serve as an Executive Vice President of Texas Oncology. I'm a breast cancer specialist, and I live in Austin, Texas. I have the privilege of talking to you today about a lot of development in cancer care, how next generation sequencing and biomarker testing has really evolved the landscape in cancer care. I think it's incredibly important for our policymakers to understand all of the developments in cancer care and how your decisions and the policies that influence healthcare can change them over time. I'm going to share my screen with you here. So cancer in 2021, none of you are spared from cancer. 1 out of 2 men and 1 out of 3 women in their lifetime will be diagnosed with cancer. It's very common. 1.7 million persons are diagnosed with cancer in this country every year. 18 million cancer survivors currently live in the United States. We spend about $157 billion in costs for cancer, and the AARP estimates about $150,000 per cost per cancer diagnosis. We know there are many factors that contribute to one's risk of cancer. Some of them are preventable. And certainly screening is some of the best prevention that you can have to prevent cancer. But the big difference that we have in cancer now too is that we have more effective therapies. Therapy has really evolved over the last 20 years, and I'd like to spend some time talking to you about that. As I think about cancer therapy in 3 sort of buckets, there's the blunt instruments from 1900 to 2000. Now those are really important and we still use them today. There are things like surgery and radiation and general chemotherapy that opts to kill cells that are rapidly dividing. But we've had some more specific changes over time because of our understanding of the molecular basis of disease. And so that's targeted therapy that really started in 2000, and then also immune therapy that has really been present since 2015. They've been real differentiators in cancer care. This is a timeline that looks at cancer care innovation, and you can see historically there have been there's been multi-agent chemotherapy in the 1960s, other systemic chemotherapies that have improved survival. But it really wasn't until the year 2000 that we have our first molecular profiling and the approval of Gleevec or imatinib mesylate in chronic myeloid leukemia. That was our real first understanding of the molecular basis of disease and how treatment could dramatically change the outcome. And I speak to that because this is really the first targeted therapy that was approved. But this is when chronic myeloid leukemia, which is a disease that impacts about 5,000 Americans per year, went from an average survival of 5 years to having 95% of people survive at 5 years overnight with the innovation of this targeted therapy. And the thought of targeted therapy in general in this space is that if you can stop the way that cells communicate and tell each other to grow, that you can render cancer a chronic disease like hypertension or diabetes. And this is really the dream of modern cancer therapy, that cancer can be chronically controlled, if not cured. So when we think about targeted therapy, that's really evolved. As we look at the distribution of biomarkers in non-small cell lung cancer, you can see this is a distribution of frequent known genetic mutations in non-small cell lung cancer that drive therapeutic decisions. So when I finished my training at the MD Anderson in 2006, we treated non-small cell lung cancer largely with chemotherapy. And I would say, while chemotherapy is still very important in the treatment of non-small cell lung cancer, most patients today now are either eligible for immunotherapy or some kind of targeted therapy, and how we treat that cancer more chronically in a way that's less toxic to patients has really evolved over time. So this is the promise of modern cancer therapy. And it's really, this is a complex slide, but really this is a way to talk about how molecular mechanisms of disease work in the way that cells talk to each other. And we call this signal transduction. But really what this kind of communication is intercellular mechanisms that tell cells that it's time to grow or it's time to stop growth. And there are many different genes and proteins that influence those choices that cells make. And so if we can upregulate or downregulate them based on our understanding of molecular profiles of cancer, we can cause cancer to chronically not grow. And that's really what we want, is we want a chronic state of non-growth in cancer cells that render cancer in remission for many years and allow patients to have long-term survival. So cancer and healthcare policy is really important because not every patient has access to these life-saving treatments, to these wonderful therapies that could potentially render their cancer a chronic disease. And they don't have access to these life-saving treatments because they don't have access to the testing that identifies that those life-saving treatments would be helpful. Sometimes the burden is simply because of insurance status. So we know that many states have lower insurance rates, and that limits people's access to care. It limits our ability to treat cancer effectively. When that happens, we see that survival for cancer is dramatically reduced. This looks at years of survival after first diagnosis with any malignancy by insurance type. And we see that insurance is a main determinant of that. In Texas, where we have a large percentage of patients that are uninsured and adults that are uninsured, this is a large problem. And you can see that mortality substantially tracks to insurance status. A problem, though, that we have is that it's not just an issue of if someone has insurance or not, but also many insurance plans, their benefit design does not cover specific molecular testing for specific cancers. And so just because someone has insurance, we can't guarantee that they necessarily have access to these different tests to determine if they would be eligible for certain treatments for cancer. We have done some looking at disparities in this patient population, and we know that low-income individuals and individuals that live in high-poverty locations in general have less access to testing. This was a study that was published in the Cancer Epidemiology, Biomarkers, and Prevention in 2019 that looked at testing for erlotinib for patients with metastatic non-small cell lung cancer. So they needed a specific molecular marker to determine if they were candidates for a particular pill-based therapy. And this looks at testing among those patient populations. What we can see is living in a low-income area or high-poverty location was a risk to not be tested. Policy also dramatically impacts this. This is a study that looked at the trends in next-generation sequencing in patients with solid tumors by race and ethnicity after implementation of the national coverage determination for Medicare, where we looked at demographic differences in next-generation sequencing by race, ethnicity, region, insurance, age, sex, and tumor type before and after the national coverage determination. So what we can see is that the national coverage determination that permitted the use of some next-generation sequencing increased the compliance with appropriate next-generation sequencing and testing among all patients, but still there was variability. I would argue that we need to have continued policy to promote insurance coverage, both private insurance coverage and also Medicaid, and expand the use of Medicare for testing for patients, as this drives therapeutic opportunity and promotes good patient outcomes. So in summary, cancer is a common problem that impacts all of us. 1 out of 2 men in their lifetime and 1 out of 3 women will be impacted by cancer. Cancer progress is unprecedented, but we need the tools to manage optimally. Next generation sequencing and molecular marker testing have been some of those tools that have been critically important in rendering cancer a chronic disease, especially in patients with advanced cancer, with stage 4 cancer, sometimes in patients with even earlier cancers, but especially in patients with stage 4 cancer. Molecular testing with next generation sequencing or biomarker testing are some of these tools that are really important to preserve and protect. Disparity exists regarding access to these tools. If you have insurance or don't, if you have Medicaid or Medicare or private insurance, and even among private insurance payers that all have variable coverage determinations around molecular profiling and next generation sequencing. So we really need policies to cover testing and provide access to improve patient outcomes and allow effective cancer treatment to be a reality. I want to thank you for listening to me and for your time today, and let you know that I have the great privilege of serving as a leader in a large organization in cancer. Empower me to be a better cancer specialist by giving my patients access to the tools they need. Thank you for your time.
That was fantastic. Thank you. So now we'll move into some discussion of what policy solutions exist to help expand access to this important testing. You can submit your questions anytime using the chat box on the right side of your screen. And at this time, I'm excited to introduce Hilary G. Goeckner with ACS CAN to talk about legislative opportunities in this area. Hilary?
Thanks so much, Representative Ryu. ACS CAN is proud to be working along many state and national partner groups representing patients, healthcare providers, and others to advance equitable access to biomarker testing. One big barrier for patient access, as Dr. Pat mentioned, is lack of insurance coverage for needed biomarker testing. But last year, both Illinois and Louisiana passed laws to align insurance coverage with robust medical evidence, including clinical treatment guidelines for this testing. So I'd like to share a short video from Illinois that talks about that law and features a few of the policymakers involved.
My name is Alicia Mandel. I'm originally from Minnesota, but I've lived in Hawthorne Woods, Illinois for 24 years. Met my husband 30 years ago in Minnesota. He was a resident and I was a nurse, and it's that story. We fell in love, had a few kids, moved here. Life's been great. A year ago, I was diagnosed with cancer. Basically, I had stage 4 colon cancer. Over Labor Day of 2020, I had 3 rounds of chemotherapy. And then after that, I think it was October, November, Dr. Kircher, she gave me a call and said, hey, guess what? Great news. And I'm like, what's the great news? My cancer's gone? Haha. And she's like, no, but we did that biomarker testing. And I'm like, yep, I remember that. And she goes, you qualified to get immunotherapy. And then she called me last Friday and gave me the amazing news, actually, that I'm sharing now publicly for the first time, because only my children know, and my husband, that everything in my colon is gone, and that I had 49, and yes, 49 positive lymph nodes in my body, and I have 0. So right now, I'm not calling it cancer-free. I'm just saying they have no signs of cancer in my body. I would not be sitting here if it weren't for God and if it weren't for immunotherapy and biomarker testing.
Biomarker testing. So think of it, biology and marker. Your body is a biological entity, and there are markers of normalcy, of normal aspects of your body, and abnormal. So biomarker testing is looking for those abnormal aspects of your body that would indicate cancer or guide a process for treatment of cancer.
I am a 2-time thyroid cancer survivor, and that's how they detected the cancer came back the second time in my lymph nodes, was after having that test.
I think the real big impact is personal knowledge about what you're facing, and in many cases that knowledge is going to overcome the fear and lead to success.
Which in my case, they did the test, they found that it was in a couple of the lymph nodes. We went back in, we removed the lymph nodes, and now it's gone, and the markers are not there anymore.
Biomarker testing is routine for certain populations and game-changing for the course of their cancer, whereas other populations, for a variety of reasons, are not able to equally access this.
So many people, because they didn't have the right type of income, didn't live in the right zip code, didn't know the right person, unfortunately, they didn't get the same type of care that other people may have gotten that had means.
And I don't think that's right. It can't be right. That can't be the world we live in. Why should I get something that somebody else doesn't? I don't deserve it any more than anyone else does.
So this bill is really designed to prevent that new technology from widening the disparities.
When the American Cancer Society brought this to my attention, I realized that this can help people throughout the state of Illinois.
This is everybody in and no one is left out. That's what I love most about this legislation.
I am very proud to say that I was part of this. And I think it is a very proud moment for the state of Illinois.
Illinois is serving as a leader, and I imagine that many other states will follow that lead soon to onboard biomarker testing.
Why wouldn't everybody want this? Why wouldn't every state in the United States say, let's do it? Look at what it's done for people. We could actually get a handle on cancer treatment. I mean, come on, this is what people have been waiting for years.
Less treatment, less pain, less sickness. I feel this eventually will end, the suffering and the death caused from cancer.
I want to thank the American Cancer Society for helping to put forth this legislation and for their tenacity and their hard work and never giving up.
ACS CAN is the real deal. I have not met a harder working, more dedicated group of people that are fighting on behalf of cancer patients. They fight and they fight hard, so I'm very impressed and really pleased to partner with them.
So many people's lives will be made better as a result of this legislation. Not that we found a cure, but it's about the closest thing that we can get, and we'll take that for now.
Oh, thank you so much, Hilary. So anyone who has any questions, please be sure to ask your question in the chat box. In the meantime, we have some questions. I have some questions for you, Hilary. Would you tell us how targeted therapies are different from the more conventional cancer treatments, that hammer that we saw?
Yeah, definitely. So I love that visual Dr. Pat uses with the hammer. So chemo and radiation, kind of what everyone pictures when you think of cancer treatment, are very blunt tools. And like chemo targets fast-growing cells. So that also hits a lot of cells that aren't cancer. And that's why chemo can cause hair loss and have other significant side effects. Targeted therapies are going after the specific mutations that can be identified through biomarker testing that are causing an individual patient's cancer to grow. So they often have fewer or sometimes no side effects. So what's really exciting about these targeted therapies, instead of treating a patient based on where the cancer was found in their body, for a really oversimplified example, let's say, oh, you have breast cancer, so these are the 5 or 6 treatment options we can choose from. Instead, doctors are able to look at the mutation and say, you have this mutation. And so regardless of where we found this cancer in your body, whether it's breast or prostate or melanoma, if you have this mutation, we know that this treatment might work really well for you.
And that must be where the late stage came in, because it may have metastasized to other sites from breast cancer, or in my friend's case, from her lung to her spine and everywhere else. So what kinds of disparities do we see in biomarker testing, and what do you think could be done to address these disparities?
Sure, that's a really important question. A lot of the disparities that we see in cancer outcomes, whether that's by race, ethnicity, income, insurance, are also seen in the biomarker testing rates. So improving access to biomarker testing is really important for advancing health equity. The research shows that people of color, particularly Black people, are not benefiting from biomarker testing at the same rates as white people. Additionally, people insured through state Medicaid programs are less likely to receive appropriate testing. We also see, though, that people in rural communities or receiving care in non-academic medical centers are less likely to benefit from biomarker testing. So there are a number of barriers to access to biomarker testing. Certainly patient awareness, providers feeling like they can stay up to date on the latest testing recommendations. But one big opportunity that can make a really big difference in this area is insurance coverage of biomarker testing, as Dr. Pat was describing. So this is, looking at people who have some kind of health insurance, whether that's through Medicare or Medicaid or an employer-sponsored insurance plan or something they purchase through the marketplace. Does their insurance plan cover the biomarker testing that their doctor thinks they need, and that these clinical treatment guidelines like those from the National Comprehensive Cancer Network say are appropriate for understanding their cancer and their disease? So most oncologists report that they look to things like NCCN's clinical treatment guidelines for determining what to do with each patient. So does this patient need further testing? What treatments should we consider? And a lot of insurance plans say that they look to those treatment guidelines in determining what to cover. But unfortunately, a lot of biomarker testing that is recommended by those treatment guidelines is not covered by insurance. And so this is an opportunity where state policy can have a big impact to make sure that everyone who meets the clinical treatment recommendations is able to get that appropriate testing. Because the alternative is either, people who have, so typically Medicare and large employer-sponsored insurance plans have better coverage of biomarker testing, but that leaves out people who have Medicaid for their health insurance or a plan they purchased on the marketplace or a small employer-sponsored plan. Those people are less likely to get have coverage for biomarker testing. And so then you're left with a scenario where maybe only people who can pay out of pocket for this testing are able to get it. And if that's the case, we're just going to see the existing disparities by income or race increase as cancer treatments get more precise and more effective. We want to make sure that everyone's able to benefit from those.
Excellent. So what do insurance coverages of biomarker testing currently look like, and who in which states are benefiting from these tests?
Yeah, so that builds a little bit on my last answer, but typically what we see is that Medicare, which is regulated at the federal level, although there are some local coverage determinations as well, generally Medicare patients are able to get the biomarker testing their doctors want for them. So we did a survey about this about 2 years ago, and 91% of cancer survivors who responded and had biomarker testing while covered by Medicare, were able to get the testing that they needed. Then large employer-sponsored plans are more likely to have robust coverage of biomarker testing. There we saw about 75% of patients with employer-sponsored insurance able to get the testing that they needed. And then patients who bought their own insurance through like a marketplace in their state, about 63% were able to get biomarker testing. So there's a range, and the good news is many patients are able to get the testing that they need, but there's also room for improvement to make sure everyone's able to get the latest and most effective testing and treatment for their cancer.
Thank you. So can you speak to the importance of biomarker testing as it relates to clinical trials?
Sure. So biomarker testing is becoming increasingly important for enrollment in clinical trials. And for many cancer patients, clinical trials offer them the best opportunity to treat and beat their cancer. So similar to how a lot of new targeted treatments are just based on the mutation, and it doesn't matter what kind of cancer you have or where it started. A lot of clinical trials are enrolling people based on the biomarkers that are in their cancer. So instead of having a clinical trial for melanoma, instead they'll be enrolling people with all different types of cancer who have X mutation. And those mutations are usually noted by a 4-letter number combination like EGRF or ROS1.
Thank you. So what opportunities for biomarker testing exist outside of cancer care? Other applications for other diseases?
Sure. So right now, the overwhelming majority of applications for biomarker testing are in oncology, especially lung cancer. So there's really advanced research, lots of targeted therapies in lung cancer, lots of exciting research happening for other cancer patients, but also lots of research happening for other disease areas. So we might hear a lot, especially in marketing from medical providers, about like personalized medicine and precision medicine. And this is really taking information from your own body, so your genes and mutations in your cells, to understand what treatments will work. And this isn't just about cancer. So lots of research happening in cardiology, in neurology, Alzheimer's, some current applications, actually targeted therapies available for some autoimmune diseases like rheumatoid arthritis. So, the cancer is certainly the cutting edge and where most research has advanced historically, but it's really exciting to see that there could be future applications. And one important note about the legislation that passed in Illinois last year is that it's disease agnostic. So it says insurance plans need to cover biomarker testing when it meets these criteria to show that there's really robust medical and scientific evidence to support that application. And that's not limited to cancer patients. So as other treatments and targeted therapies come to market for other conditions, those plans will have to cover those as well.
Great. I would love to see that bill and also the fiscal note, but it sounds like we've come a long ways over the last 20 years. So this sounds expensive. Will biomarker testing increase costs?
That's a great question and a perfect follow-up to your note about fiscal note. So Milliman just put out a study in the last couple of weeks looking at cost implications of this type of legislation and kind of what would this mean for premium impact on insurance plans. So they projected somewhere from 14 to 50 cents per member per month for private insurance plans. But what's really important, so that accounts for potential increase in use of biomarker testing. This doesn't count any cost avoidance that you can get with biomarker testing. Without biomarker testing, often oncologists are kind of guessing and trying out different treatments to see what will work. And those treatments can be really expensive. Ask anyone who's been treated for cancer or knows someone who's been treated for cancer. There can be enormous costs for treating that, even with good insurance. So the biomarker testing, the test itself can range anywhere from under $100 if you're just testing for a single gene, or thousands of dollars if you're looking at a larger panel to identify more mutations. But that helps doctors say, actually, that $80,000 worth of chemotherapy that we would have prescribed you if we didn't know about this mutation, we're not going to do that because we know that's not going to work, or we know this other treatment will work better. So it's really important to look at the biomarker testing and the targeted therapies in the context of a cancer patient's treatment options. So you're able to avoid treatments that would be perhaps ineffective, more quickly get on a treatment that's going to work and avoid complications. So something that I've heard over and over again talking to patients who've benefited from targeted therapies based on their biomarkers is that they're able to keep working and living their lives. Unlike someone who's going through chemo and radiation, who maybe is just tired all the time and missing work, is that a lot of people, I won't say all, but a lot of people with targeted therapies are able to continue living their life, and they take a pill or get an infusion once a month to keep that cancer in check. But other than that, they don't feel really sick all the time, which is really exciting.
Yes, definitely for quality of life, as well as, of course, surviving the cancer itself. So if you would explain the difference between genetic testing for an inherited cancer risk and biomarker testing for a patient's tumor, a specific tumor.
Sure. So one way to kind of simplify this is to think of genetic testing as something that might happen before someone's diagnosed with cancer, and genomic or biomarker testing happening after they're diagnosed with cancer. And I'll get into a little bit of nuance there, but genetic testing is looking for inherited mutations, so something that you got from your parents, to see if you're at higher risk for getting certain cancers, or if you're could potentially pass on those risks to your children. And so that's looking at inherited mutations, things you got from your parents, and what that means for maybe how often you should be getting screened, or if you might want to take some other preventive measures because you're at high risk for certain cancers. Biomarker testing, or what people sometimes call genomic testing, is looking after you've been diagnosed for cancer. How aggressive is this cancer? Will it respond to these targeted therapies? That sort of thing. And many, they're not all of those mutations are acquired. So you didn't have them at birth. They didn't come from mom and dad, but you've had these mutations evolve in your cells over time that are now driving this cancer to grow aggressively. So it's looking more kind of after someone's been diagnosed with cancer, which treatments will work, or what can we say about your cancer? Though certainly after people get diagnosed with cancer, they might also get genetic testing to see, what does this mean for other cancers or for my children and grandchildren's risk?
Yeah, excellent. As a brand new grandma, yeah, I do pay a lot more attention to people who get really scared when somebody is diagnosed with cancer, and then they worry for their own health as well. Just 3 more questions to go. So why would we tie the coverage requirement for the national guidelines and recommendations, and why not just say, hey, we know it works for these particular cancers, so let's just cover those and reduce that fiscal note?
Sure. So that's a great question. The Illinois legislation, as well as bills under consideration in several additional states now, spell out a couple sources of evidence for when biomarker testing should be covered. So that's FDA-approved tests or companion diagnostics for FDA-approved therapies. That makes sense. CMS coverage determinations. So when Medicare decides that this should be covered for Medicare beneficiaries. Other plans should also follow that evidence. And then nationally recognized clinical practice guidelines. The one I mentioned earlier was NCCN, the National Comprehensive Cancer Network. And so what's really exciting in this area is there's so much happening. And we want to make sure that this coverage keeps pace with the science, not getting ahead of the science. Only when the testing is proven to be really helpful for patients and helpful for shaping their treatment decisions, then it should be covered. Because, as you know, changing laws can be challenging, and we don't want to have to go back year after year after year and update the statutes and say, oh, last year, we said it was really good for non-small cell lung cancer and melanoma, but actually there's all this new research now about pancreatic cancer, and so we want to make sure those patients benefit too. It's a efficient and forward-thinking process to tie the coverage requirements in statute to those really robust sources of evidence going forward so that patients can benefit.
And there's also something called rulemaking by the agencies.
Right.
So a question is whether ACS CAN will have resources for the state legislators to basically copy the finest form of flattery and to introduce ourselves to pass the policies on health insurance, including biomarker testing for cancer patients.
That's a great question. So there are a couple resources linked on the event page now. So you can click on some fact sheets about biomarker testing generally and biomarker testing and health equity. There's more information at fightcancer.org/biomarkers. And then I will also add that we are working in many, many states, not quite everyone yet, but soon on this issue specifically. ACS CAN is working in every state and US territory on policies to help prevent and treat cancer. But this is a really exciting priority for us because it's so important to helping patients get the best treatment for their cancer. So we are working in coalition to educate lawmakers through events like this about the exciting opportunities around biomarker testing, but also to advance legislation like that passed in Illinois. I'm happy to call out our friends in Arizona, where the House unanimously passed coverage of biomarker testing just last month, and that is now under consideration on the Senate side. And there are bills introduced in several other states as well. But as we've kind of covered in the last 30, 40 minutes, this is a complicated issue. There's a lot of nuance to it. So we are trying to be thoughtful about educating lawmakers and partners and potential opponents of this about what this issue is, what it means for patients, and what the legislation would do. So we aren't running or asking lawmakers to carry bills in all 50 states at once, but trying to work through this thoughtfully and soften the ground, educate lawmakers, build up champions to help advance this issue across the country.
And women legislators are very willing to step up. So the last question, is there any targeted therapy at this time for Alport syndrome that you're aware of?
I am not aware. I would have to look into that one. I'm not sure exactly, but happy to give it a Google. But I will also add, I know that we've had a few questions about slides and recordings. So we will work with Women in Government to get the recording of this event shared with everyone. So if you weren't able to catch the first few minutes or you want to share it with some colleagues, we encourage you to do that, and we'll get the recording out to everyone in the next day or two.
Oh, thank you so very much, Hilary. We are out of time for today, and I really appreciate you organizing and joining us, everyone else, for today's conversation. I would like to also thank our speakers and Women in Government for hosting us. So let's keep the conversation going, and please check out the resources linked on the right side of your screen, and you can learn more at fightcancer.org/biomarkers. And please join Women in Government again for our next event, an upcoming webinar on preserving and promoting professional certifications. And that's on Monday, March the 28th at 2 p.m. Eastern Time or 11 a.m. Pacific. And so the details are on womeningovernment.org. Sorry about that, womeningovernment.org. I say that all the time. So thank you again, and we'll see you soon.